Low back pain is the leading cause of years lived with disability worldwide. In chronic cases, up to 40% of that pain originates from the internal disruption of the intervertebral disc itself, a condition known as discogenic low back pain, or DLBP. For decades, the standard management for DLBP has followed an empirical ladder. A patient is escalated sequentially from pharmacological modulation and physical therapy to generic steroid injections and eventually to surgery. This linear approach consistently fails during the intermediate, minimally invasive stages. Clinicians apply uniform treatments to a condition that is highly heterogeneous, managing the symptom rather than isolating the precise biological pain generator. Because interventions are mismatched to the underlying pathology, patients routinely exhaust intermediate care. This funnels them towards spinal fusions, contributing to the high incidence of failed back surgery syndrome. These clinical failures stem from a central assumption that discogenic pain is a single, monolithic structural disease. The biological evidence reveals a far more complex reality. Effective management requires recognizing DLBP as a collection of distinct conditions. Successful outcomes depend on targeted phenotyping, identifying the exact structural and biological mechanisms driving the pain in each individual. This flowchart presents a phenotype-driven precision framework. Focusing on the third tier, treatment branches into mechanism-specific options. This links specific biomarkers directly to interventions, stratifying patients into 4 clinical phenotypes: vertebrogenic, annulogenic, mixed, and neurosensitized. Implementing this framework requires clinicians to shift their focus from gross anatomy towards the specific neurovascular and immune cascades driving disc pathology. Matching precise biological markers to targeted interventions shifts the clinical process from empirical guesswork toward a deliberate, mechanism-matched selection process. Under physiological conditions, a healthy intervertebral disc is largely aneural and avascular. Pain receptors and blood vessels are restricted to the outermost layers of the annulus fibrosus. This diagram outlines the triad of disc degeneration, operating as a continuous loop of structural damage, functional impairment, and metabolic dysregulation. When the structural matrix breaks down, the normally immune-privileged nucleus pulposus is exposed directly to the systemic immune environment. This exposure triggers a sustained inflammatory response. Pro-inflammatory cytokines flood the local tissue, disrupting extracellular matrix homeostasis and promoting rapid catabolic degeneration. These inflammatory mediators stimulate neurotrophic and angiogenic pathways, upregulating nerve growth factor and vascular endothelial growth factor. This altered microenvironment permits the pathological penetration of microvessels and nociceptive C fibers deep into the inner annulus and the nucleus pulposus. Structural matrix breakdown alters local biology, physically inviting pain receptors into the disc. This establishes the anatomical prerequisite for discogenic pain, setting the stage for distinct clinical presentations. This biological cascade manifests clinically in 4 specific ways, beginning with localized structural failures. In the vertebrogenic phenotype, pain is driven primarily by mechanical stress and inflammation at the vertebral endplate. The mandatory imaging biomarker is modic type 1 or 2 changes on an MRI, indicating a sensitized intraosseous basovertebral nerve. The targeted intervention here is basivertebral nerve ablation, interrupting nociceptive signals precisely at the inflamed endplate. The second presentation is the annulogenic phenotype. Here, nociceptive nerve fibers grow directly into radial or circumferential fissures within the annulus. The visual biomarker for this is a high-intensity zone on a T2-weighted MRI. The precise intervention is bipolar cooled radiofrequency ablation, or biacuplasty. It delivers controlled thermal energy to destroy those specific infiltrating nerve endings within the annulus. Isolating the localized structural failure dictates the intervention, whether the specialist must ablate the intraosseous nerve or the annular tissue itself. The framework addresses complex presentations, starting with the mixed phenotype. These patients display overlapping pathology, featuring modic changes at the endplate and active annular fissures simultaneously. Because multiple pain generators exist, combined denervation strategies are required. The fourth and most challenging presentation is the neurosensitized phenotype. Here, the pain profile is disproportionate to mild structural imaging findings. The nervous system is amplifying the nociceptive signal. In the presence of central sensitization, local thermal ablations inside the disc are futile. Management requires advanced neuromodulation, like dorsal root ganglion stimulation, to block transmission at the spinal level. Screening for central sensitization prevents unnecessary local surgeries and directs the clinician towards systemic neuromodulation. Why do two patients with identical structural MRI scans report drastically different pain and disability scores? Patients are managed within a biomechanical, neurobiological fascial continuum, where structural disc issues interact with the surrounding soft tissues. Disc instability and altered load distribution force the paraspinal muscles into a state of chronic compensatory hypertonicity. This muscular overactivity generates mechanical stiffness in the thoracolumbar fascia and localized myofascial trigger points. This fascial dysfunction acts as an amplifier, continuously feeding peripheral nociceptive input into the nervous system and fueling central sensitization. Because these are soft tissue dynamics, a static MRI cannot capture them. Specialists must utilize dynamic ultrasound to visually assess fascial gliding and thickness in real time. If these functional pain generators are identified, Tier 2 interventions like ultrasound-guided dry needling can be applied to interrupt the peripheral input. Myofascial dysfunction functions as an amplifying modifier to the underlying discogenic pain, necessitating a Tier 2 resolution before escalating to the structural targets of Tier 3. Because the pathology involves structural damage, neurosensitization, and functional modifiers simultaneously, relying on a structural MRI is clinically insufficient for precise phenotyping. Accurate diagnosis requires concordance across three pillars: clinical presentation, structural MRI, and dynamic ultrasound. This must be paired with quantitative functional scoring, like the VAS and ODI, to ensure the specific phenotype is objectively verified. Provocative discography carries a high false positive rate and presents a mechanical risk of accelerating disc degeneration. It is generally reserved for select surgical candidates when non-invasive tests remain inconclusive. Concordance across the clinical, structural, and functional domains is mandatory before any needle or scalpel touches the patient. When targeted ablations and conservative care are exhausted without yielding significant functional improvement, patients reach Tier 4, surgical reconstruction, via anterior fusion or total disc replacement. But surgery is strictly a salvage option. It is reserved for refractory, structurally dominant disease exhibiting absolute clinico-radiological concordance. A success-mapped pathway flows logically from symptom presentation, down through functional modifier treatment, directly into a precise, biologically matched intervention. This precise, mechanism-driven pipeline effectively replaces the old trial-and-error escalation that defined the past 2 decades of spine care. By adopting this phenotype-driven precision framework, specialists can optimize interventional selection, halt unnecessary surgical escalation, and directly reduce the incidence of failed back surgery. Because the pathology involves structural damage, neurosensitization, and functional modifiers simultaneously, relying on a structural MRI alone is clinically insufficient for precise phenotyping. Accurate diagnosis requires concordance across 3 pillars: clinical evidence of loading intolerance, structural MRI phenotyping, and dynamic ultrasound assessment. This must be paired with quantitative functional scoring. Evaluating patient-reported outcome measures alongside a central sensitization inventory score ensures the specific phenotype is objectively verified. Provocative discography carries a high false positive rate and presents a mechanical risk of accelerating disc degeneration. But surgery is strictly a salvage option. It is reserved for refractory, structurally dominant disease exhibiting absolute clinico-radiological concordance. A success-mapped pathway flows logically from symptom presentation down through functional modifier treatment, directly into a precise, biologically matched intervention. This precise, mechanism-driven pipeline completely replaces the blind, trial-and-error escalation that defined the past 2 decades of spine care. By adopting this phenotype-driven precision framework, specialists can optimize interventional selection, halt unnecessary surgical escalation, and directly reduce the incidence of failed back surgery.